Hi, my name is Amanda Farrellow. I am the Communications Officer here at the Canadian Institute for Substance Use Research. And I want to thank everyone for coming out today to Scott's talk. I just want to start with acknowledging that we are on the traditional lands of the Songhees, Esquimalt, Satsum peoples, the universities, and the traditional territories of the Lekwungen speaking peoples. And so I just want to take a moment to acknowledge that. And I think it's particularly important to think about this when we're talking about substance use policy and substance use, because this has disproportionately impacted Indigenous people here in what we today call Canada. And I'm going to turn it over to our director, Tim Namey, to introduce Scott. So thank you everyone for coming.
Yeah, this is a nice turnout. I'm Tim Namey, and we're really happy to have Scott here today. A native son of White Rock, BC, actually. Scott is the Chief of Adolescent Medicine at Mass General Hospital in Boston, and he's an Associate Professor of Pediatrics at Harvard Medical School. He is an internationally renowned expert in teen health whose clinical care and research focus on preventing and treating drug and alcohol use. His work has been funded by the National Institutes of Health and what remains of the CDC, no, just kidding, among other funders. His research has been published in the New England Journal of Medicine, JAMA, Lancet, and other leading journals. And he's been featured in the New York Times, the Washington Post, CNN, NBC, NPR, etc. In 2023, he was selected as the Presidential Leader Scholars Program, which brings together national leaders committed to facing critical challenges in partnership with the Clinton Presidential Center and the George W. Bush Presidential Center. And he also serves on a WHO advisory group establishing standards in the measurement of adolescent health outcomes across the globe. And on a personal level, I want to say that it is a great honor to welcome my friend and former colleague at Boston Medical Center, Scott Hadland, to Caesar. And
thank you so much, Tim, and thank you all for having me. It's really exciting to be back here. As Tim just mentioned, I grew up just across the water in White Rock, British Columbia. All my family is still there. I'm actually taking the ferry across to go see them tonight. I'm going to have a burger on the ferry today that I'm really excited to eat as I make myself back at home here. So it's really just wonderful to be back. Right? Is it really? It's good to be back, but it's also quite humbling to be back. As I became interested in the world of substance use and substance use related public health and research in clinical care, it was all because I was inspired by work that I saw happening here in British Columbia as I was growing up. And it's humbling to be back because I realized that so much about the crisis that is all around us has changed so much in the time that I've been away. I've now been fortunately, actually more so unfortunately, living in the United States almost as long as I ever lived in Canada before moving away. And it is, as I said, quite humbling to realize the ways in which this crisis has just changed and moved much more quickly than I've been able to take stock of in many ways, and that I think our public health efforts have been able to keep up with. My own work is that I lead our adolescent medicine division at Mass General Hospital and Harvard Medical School, where we care for a little over 2,000 adolescents and young adults between the ages of 13 and 29. And we do a lot of primary care in the United States. Pediatricians actually provide the bulk of primary care to adolescents, with family medicine providing care for about a third of adolescents and pediatricians providing care for about 2/3 of adolescents in the country. So we actually are doing a lot of sore throats and runny noses and ear aches and routine vaccines and annual physical exams and treating acne for teenagers. And then we also do a lot of subspecialty care, and that subspecialty care is that we get a lot of referrals from other doctors out in the community that ask us to take care of patients to help support them if they're having issues related to, for example, eating disorders or mental health disorders, or addiction or substance use related conditions. And so as I speak today, what's that? Yeah, it's good. I'm just, it looks like I'm being the button, but I'm not. It's, gosh, I lost my train of thought there, but no, it's okay. What I wanted to say is that the way that my framework and the way I come at this issue is that I'm a clinician and I'm providing care in a clinical context. And I think one thing that I've learned a lot today about as I've been here visiting folks from Caesar and seeing the really robust community engaged work that's going on here is that, there's a whole other set of really critical services that we need to be delivering to young people to reach them where they are. And I sort of fully acknowledge that a lot of what I do is attached to an ivory tower and requires patients and families to come in to see us. And so, I acknowledge that that is the framework in which I come at this today. But I'm hoping that as we sort of talk about evidence-based treatment and talk about the clinical care that we're delivering, that helps to inspire ways that we can bring this work out into our community. In fact, I'll be discussing today some of the ways in which we're really trying to make sure that we're meeting young people in our own community to get them the services that they need where they are. And just want to say I have no conflicts of interest and want to acknowledge our funding, which, as Tim mentioned, comes from the NIH and the remnants of the CDC. I want to start by just grounding today's talk in the story of one of my patients. This is Brendan, and his family has given me permission to share his story. Brendan is a young man I got to know when he was 19. He was, by all accounts, a young man who was thriving in high school. He played for the high school baseball team in Attleboro, Massachusetts, and was a really wonderful, athletic young man who, when he was about 16, his father, who he's really close with, was diagnosed with cancer, and unfortunately, his cancer trajectory was really rapid, and he died very quickly within a few months of diagnosis. And Brendan just never really recovered from this, and the grief that he experienced around this really triggered a lot of other mental health concerns for him that ultimately led to him using substances and ultimately led to him using opioids and stimulants quite heavily. And so by the time I got to know Brendan when he came to my clinical care as a 19-year-old, he was already using opioids and stimulants really quite heavily. And actually, Brendan did quite well with a lot of the evidence-based treatments that we were able to provide him. Unfortunately, when COVID struck, like it did for so many people all across North America and the world, COVID really isolated him and made it hard for him to come into our clinical settings, which are already very difficult to get into for many people, but became even more difficult because there were all these rules about who could come to the hospital and all these ways in which we were triaging care to focus on the people who were the most sick, and people who had addiction or mental health problems often weren't able to get in through our doors. And it was in this context that he was using drugs with some acquaintances in 2020 and was actually killed by one of the people that he was using drugs with. And to this day, his murder is actually unsolved. And there's a lot of things that really come up in Brendan's story for me. The first one is the ways in which I wasn't able to give him the care that he needed during a time that was so isolating. Another one was the way in which, yes, he was struggling with addiction, but at the same time, there were ways in which his life was at risk through other ways, and ways in which he was at risk for violence by virtue of the fact that addiction is such a stigmatized condition that is sort of driven into places where it's hidden from people and where violence can happen. And there's also the way in which he never received justice, that his death remains unsolved, and I don't perceive that there's a lot of activity or resolution to try to bring answers to his family. And so it just is a reminder that when it comes to substance use and substance use disorders, there's all this stuff that we really need to make sure that we are taking on, because we have a lot of work to do what's right for people. And I also want to acknowledge that there's a lot of attention right now on young people. There was this article that folks may have seen that I believe was published last week in the Canadian Medical Association Journal that just really reminds us that although when we talk about the overdose crisis in North America, we're often focused on adults, and many of our services are focused on adults, that there is really just this really critical way in which young people have also been impacted. And in the US context, we're now at a point where overdoses and poisonings are actually the third leading cause of death in children under age 19. So of all children between the ages of 0 and 19 in the United States, overdoses are the third leading cause of death. And number one is firearms. Number 2 is motor vehicle crashes, and number 3 are overdoses and poisonings. And so, for me as a pediatrician, it's so important to be talking about this because we spend all kinds of time in pediatrics thinking about, items 4, 5, 6, 7, 8, and 9 on that list of things that impact the mortality of young people, and yet we spend almost no time in the field of pediatrics talking about this third leading cause of death. And so it really is heartening for me, and then also disheartening the extent to which we need to really focus on this as a field. But it's heartening to me to see that for the sort of leading Canadian medical journal, there's appropriate attention being paid to this issue. And so by the end of this entire 90 minutes, and I've saved lots of time at the end of this for questions, I've only got about 33 or so slides. I want to make sure that by the time we've sort of had today's full discussion, we really are acknowledging and understanding the ways in which children and adolescents haven't been spared from the rise in morbidity and mortality attributable to opioids. And we'll spend time talking about the epidemiology of overdose and substance use related harm in young people across North America. We'll take actually a quick detour to talk about opioid prescribing, because I think this is a really interesting and important aspect, because a lot of young people who struggle with addiction have also experienced pain, and pain is wrapped up in the process of developing an addiction. And so we'll spend a little bit of time just talking about opioid prescribing in young people. And then last, we'll talk about evidence-based treatment and harm reduction for youth. Again, remembering that my lens is often in a clinical context, and I would love to hear from you all about the ways in which you have seen this work well in your communities. So starting with the epidemiology. These are some small figures I realize now as I see them up on the screen, but I just want to highlight that the data I'm about to show you for Canada and for the United States really show that just like for Brandon, there's this way in which drug-related deaths really increased as COVID hit. And specifically, if you home in here on the children and adolescents between the ages of 0 and 19 across Canada, and if you home in on the young adults between the ages of 20 and 29 in Canada, and you look at the death rate, which is really the second column under 2019, and you follow that out to the right side of the figure, which is 2021, you just see this huge increase in opioid-related overdose deaths that took place in these age groups, that there just has been this massive skyrocketing that took place over COVID. And what happened in the United States, and what has happened here too, is that sort of those overdoses reached a new elevated sort of level after COVID, and then largely stayed there. In the United States, we had a slow acceleration, and there's also a suggestion that that numbers have stayed quite high here in Canada as well. I am sharing with you some data from a colleague and friend of mine, Dr. Matt Caruana, who's at BC Children's, and he and his group have looked at overdose-related, substance use-related hospitalizations and deaths across Canada using national data of 0 to 20-year-olds. And what you can see is that, somewhat interestingly, the number of hospitalizations related to drugs has actually remained relatively constant. But the overdose deaths that are happening out in our communities have climbed and climbed and climbed. And that may reflect the fact that we have an increasingly toxic drug supply that is resulting in more sort of instantaneous death of young people out in the community. And so many young people aren't even able to make it into the hospital, to the extent that they even trust us to manage their overdose when they do come to a hospital. In the United States, these are what our data look like over that same time period of roughly sort of 2018, 2019 through until the end of 2022. And so this is a figure that we published last year. And if you look again, this sort of describes what I was saying, that for 2018 and 2019, there was kind of this sort of, there were overdoses certainly happening among young people. So these are adolescents between the ages of 14 and 18 across the United States. So this is basically high school students. There were overdoses that were happening in the background. Interestingly, even before COVID strikes, so COVID strikes right about here, which is March of 2020. And even before March of 2020, you actually start to see that overdoses are ticking up among adolescents in the United States. And that actually represents likely the fact that, again, the drug supply was becoming increasingly toxic. Fentanyl was already everywhere throughout the drug supply in the United States, and we'll talk about fentanyl in a second. But what was happening likely is that it was permeating the drug market in a way that adolescents were increasingly accessing it and increasingly using it. And so even before COVID strikes, you start to see that overdose deaths are ticking up. But then COVID hits in March of 2020, and that's where you see this huge taking off of the drug overdose rates. And not only do you see that there's this big taking off, but then if you look at the right side of the figure, if you imagine drawing a line of best fit between those points on the right side of the figure, you could see that that line of best fit is actually continuing to increase. So we reach this new elevated level of drug overdoses, and then those overdoses continue to rise after that. And the drugs that underlie our overdose crisis in the US are very similar to the drugs that underlie the overdose crisis here in Canada, and that is that it's really fentanyl, which is an opioid, which is highly potent, that is permeated sort of throughout the drug supply, both in Canada and the United States, and that in young people puts them at particularly high risk because many young people don't have any tolerance to opioids. They haven't been using opioids for a long time, and so when they use a highly potent opioid, they're at much higher risk of overdose when they do use, especially if they might just be experimenting and sort of trying an opioid, once or twice or maybe just 3 times. And so this figure shows, if you look at 2010 on the left of the figure all the way up to 2021 on the right, again, you start to see this beigeish line that starts to take off in 2016, 2017, 2018, and 2019. And that's fentanyl sort of entering into the drug supply. Young people are beginning to access it. And then when you hit 2020, all of a sudden that line just absolutely skyrockets, and you see that drug overdoses basically quadruple, even more related to fentanyl among young people. I do think it's worthwhile that our studies have shown in the US context that even though fentanyl, yes, is involved in 8 out of every 10 overdose deaths in young people in the United States, actually, once you start to enter into young adulthood, as young people get older, increasingly the overdose deaths that we observe involve not just fentanyl, but other substances as well. And so you start to see that other stimulants and benzodiazepines start to enter into causes of drug overdose deaths alongside fentanyl. And so the most common, so first of all, above age 21 and older in the United States, it's more common for a drug overdose to involve fentanyl plus another drug rather than just fentanyl alone. And those other drugs are most commonly, number 1, cocaine, number 2, methamphetamine, and then number 3, benzodiazepines. And benzodiazepines are medications like alprazolam, which goes by the brand name Xanax. They're sort of sedative medications that can contribute to overdose. And all of this is happening despite the fact that actually, if you look at young people, these are data again from the US, but it's a similar set of data that you see if you look at Canadian numbers, that actually fewer young people than ever are actually using drugs. So drug use rates are actually going down across North America. It's just that when people do use drugs, they may be using drugs that come from a more dangerous, toxic drug supply that is more likely to result in overdose. And so if you ask the question, how many young people are sort of misusing prescription opioid pills like oxycodone, how many young people are using them in ways that doctors didn't intend or didn't prescribe them, those numbers are actually at an all-time low right now. And so if you look at our national data in the US, this figure goes from 2000 on the left to 2024 on the right. And you see that there was this period of time, sort of in the late 2000s, early 2000 teens, where about 1 in 8 adolescents were using or had used a prescription opioid for non-medical purposes. So there really was sort of a high rate of medicine or medical misuse of opioids. But those numbers have absolutely plummeted. And actually in 2024, they reached an all-time low among young people. So we actually have this enormous public health success in that there's less use of these pills, and yet overdoses are going up because the drug supply is more dangerous. I will say, though, that the proportion is not 0. It's actually 1 out of every 62 students in the United States, which may not sound like a lot, but if you do the math, that's about 1 student for every 2 high school classrooms. Multiply that across the United States, and you can start to see how there's a mounting public health problem. The other thing is, again, I like to point out to my pediatric colleagues that 1 in 62 is the prevalence of things like diabetes or hypertension, that we get all this training in when we're getting our training in pediatrics, but we get next to nothing about how to talk to young people about substances. And of course, part of the issue, and I think folks in this room are probably aware of, is that a big problem is actually pressed pills. And this has definitely been the issue in Massachusetts. I know that things have evolved a little bit here where pressed pills may not be as prevalent as, say, powdered fentanyl in the context of many parts of British Columbia. But in Massachusetts, where I work, these pressed pills are still the primary way in which most young people are using opioids. And so the issue here is that these are pills that look exactly like, or almost exactly like, real bona fide medications, but actually are counterfeits that are produced on the illicit market and contain fentanyl. And again, because fentanyl is highly potent, because many young people don't have any tolerance to opioids, and because young people may not realize what it is that they're using when they use one of these pills, they put the young people that I work with at a lot of risk. And so this left panel here on top shows blue, what we call M30s. These are basically oxycodone tablets, and immediately underneath them, the blue pills that you see underneath are counterfeit tablets made to look like those bona fide pills that are right above them. The middle panel actually shows on top real Adderall tablets or mixed amphetamine salt tablets, and immediately underneath it are counterfeit tablets that contain methamphetamine. What's really interesting is, this slide is now a little bit outdated. These are pictures from the U.S. Drug Enforcement Administration from 2021. And I had heard about these methamphetamine contaminated tablets, but hadn't really seen them among my patients. And now we're starting to see a lot of these in the college scene on the East Coast of the United States. So it's interesting that, it's got this picture, I hadn't really seen them, and now I'm starting to see them a lot in my practice. And then the panel on the right shows a tablet of alprazolam, or brand name Xanax, a benzodiazepine that again has sedating properties. The white tablet there is a real tablet, and then the yellow tablet next to it is a counterfeit tablet that actually contains, in this case it was fentanyl, but sometimes they can also contain other high potency benzodiazepines that can contribute to overdose. But again, the idea here is that it looks like the real thing, but actually can have a highly potent substance in it that you can overdose on. So with that as the backdrop, we don't have a lot of data about nationally in the US or even North America more broadly, what does the full picture look like under which young people are overdosing? But a multi-state study that came from the US Centers for Disease Control and Prevention showed this, that in the US among young people aged 10 to 19 who overdose, at least 1 in 4 overdose deaths involve these counterfeit pills. I think this is a vast undercount because many jurisdictions either aren't testing for fentanyl when they find it at the scene of a death, and or young people often will only buy 1 or 2 tablets and then may use them and overdose, and then there may not be a tablet or a counterfeit pill left to test. And so I think this 1 in 4 is a huge undercount, but these are what our national data show. Most overdose deaths are actually occurring at home, which is really interesting because I think we sometimes hear about or see in the news and might come to believe that overdoses are happening at schools or out in the community. And yes, they are, but actually most overdose deaths are happening in private residences, often where young people live. 2/3 of the time, there's actually somebody else at home who could have potentially intervened in the overdose. But 60% of the time, the teen is pulseless by the time emergency medical services have arrived. And only in 1 out of every 3 overdose deaths was naloxone given. And naloxone is the overdose reversal agent that in the US we tend to predominantly use nasal spray naloxone. It's very easy to administer. Families could have it at home and use it to reverse an overdose immediately and save a life within minutes, but it's given in the minority of deaths that occur in the US. So with that as the backdrop, I do want to take a little detour just to talk about pain treatment and talk about opioids, because again, I think that this is sometimes wrapped up in young people's use of pills. Certainly is a thing that I see in my own clinic. And we've actually developed new guidelines that can help guide doctors in how to think about treating pain in young people. And I just want to sort of illustrate that when I was in medical school, I started medical school in 2004, and I so distinctly remember getting lectures in which people in a classroom like this up at a podium would say, pain is the fifth vital sign, it's cruel and unusual to not treat pain. If you treat somebody who has pain with an opioid, they can't get addicted. There were these things that we said. And of course, a lot of them proved to not be true, and we learned that as the 2000s and 2010s evolved, that we started to have an overdose crisis that in particular in the US, in many parts of the US, was driven by overprescribing of pills. And so then you started to see emergency departments and entire clinics in the US say, hey, we're getting out of the business of prescribing opioids. We're not going to give any opioids out at all. Don't come to our clinic. We're not going to give you anything. And that doesn't really make sense either, right? We know that severe acute pain benefits from use of opioids at times in certain situations. And opioids have been around for millennia. They're a central part of treating pain in clinical practice. And so, where I think it's really important that we try to come down when it comes to pain treatment is really thinking about the fact that, we should actually still prescribe opioids sometimes because they're effective for severe acute pain. We should just be thoughtful when we do it. And if you look at prescribing rates for opioids in the pediatric population, they plummeted. So there were actually a lot of opioid prescriptions that went out, particularly young adults. That's the orange line representing 20 to 24-year-olds. And you can see that as this figure goes from the left to the right, from 2006 to 2018, opioid prescriptions just plummet in young adults. There's another line immediately below that that's sort of the dark blue, navy blue line there. That represents adolescents between the ages of 15 and 19. Again, they had a lot of opioid prescriptions that were being given to them. Those have plummeted a lot. And a big part of that was sort of prescribing of opioids in around procedures. So it might have been dental procedures or trauma or surgical procedures, young people getting a lot of opioids prescribed to them after those. And that's really plummeted. And I would say in the aggregate, that's probably good. We don't want there to be a lot of excessive, unnecessary medications of any type that are controlled out in communities unless it's done in a thoughtful rollout. And this clearly was not that. But on the other hand, this also likely represents many young people who had severe pain, who never got their pain treated because a clinician said, I'm not prescribing an opioid. And so I think it's a double-edged sword that can have some adverse consequences. Very fortunately, we actually know when it comes to opioid prescribing, what sort of the true risk of an opioid prescription is. And then we also know some of the risk factors for young people who are going to go on to have a problem with opioids. And so actually it turns out if you look at national data and ask the question, after an adolescent or a young adult gets prescribed an opioid, what proportion is going to go on to have a problem with that opioid? It's actually only about 1 in 300, which is pretty low. It means that for me as a clinician, when I'm prescribing opioids to patients, and I don't do it that often because I don't need to, 299 times out of 300, the patient in front of me is probably going to be fine. They're not going to have an overdose from that opioid. They're not going to develop addiction from that opioid in the year ahead. So that's really reassuring data. And on top of that, we know what the risk factors are. So studies have looked at what are the prescription-related risk factors for developing a problem from an opioid, and what are some of the individual level factors that are associated with developing a problem. And it turns out that long-acting opioid formulations like long-acting morphine or long-acting oxycodone are higher risk. It turns out that when we give high doses of opioids, that's higher risk. It turns out when we give patients long prescriptions of like a week or more, that's associated with higher risk. What's really interesting, though, is that actually it's the patient-level risk factors that are probably much bigger as you look at studies, that they're associated with much greater risk. And I've listed a few of the documented risk factors there, but I actually really want to home in on the final 2 bullet points here. The first one being mental health disorders, meaning mood and anxiety disorders, psychosis, ADHD, trauma-related conditions. Because untreated, these are actually associated with probably about a 4 to 5 times greater risk of developing a problem with an opioid when you're prescribed one. And that risk multiplication is actually much bigger than some of those factors I talked about above related to the prescription itself. And then this final bullet of other substance use, I put 3 asterisks next to it because here the risk is probably about 20 times greater, meaning that if a young person is already starting to struggle with cannabis, alcohol, or nicotine, and then you prescribe an opioid, those are young people who are going to be at a much higher risk of developing a problem with addiction when we prescribe to them. Now, again, it doesn't mean that we don't prescribe them opioids. In fact, in my practice, I have patients who have a history of opioid addiction who undergo a really painful surgery and actually need an opioid to treat their pain. And we can do so effectively. We just do so with really close, careful communication, close follow-up, and in partnership with each other. And it's just a reminder that these are risk factors that impact our practice but don't change what we ultimately do. We just do so very thoughtfully. And so I was very fortunate to lead a committee for the American Academy of Pediatrics that came up with best practices because pediatricians really wanted to get some guidance on what's the best way to go about prescribing opioids safely. So here's the set of guidelines that we came up with. First of all, whenever we're treating a young person who's in pain, not everybody needs an opioid. And in fact, we often can treat pain very effectively without use of an opioid by making sure that we're maximizing our non-pharmacologic options, right? We know that relaxation technique can be very effective. Meditation can be very effective. Hot and cold packs for certain types of pain can be very effective. And then, of course, there is some severe pain that just is going to need a medication. And even in those situations, we often can manage the pain with acetaminophen or with ibuprofen, sort of our non-opioid medication options. But then to the extent that we do need to prescribe an opioid, we still do so if somebody needs it because it is, it's not good to leave somebody with undertreated pain because that's associated with a lot of distress for patients and for their families. And so when you do need an opioid, you use the lowest dose needed of a short-acting formulation for a short period of time, usually only a few days is all that's needed. We don't use opioids as monotherapy, meaning that we're always combining them with these other modalities. We don't use long-acting opioids for acute pain because they're associated with more risk. And actually, interestingly, there's a lot of pediatricians, and I wonder if this might be the case for GPs here too. There's a lot of folks in my field that feel like codeine and tramadol are sort of less potent opioids and might be safer to use. It actually turns out that these medications are metabolized differently by some children and actually themselves are associated with their own unique risk of overdose when we prescribe them. And so actually we're moving away from using codeine and tramadol altogether. Even though when I was growing up, that was like the thing that the doctor gave you when you had an earache. Other safety considerations, when we're prescribing opioids, we always want to make sure that patients aren't on other sedating medications. We look into our sort of prescription monitoring system as doctors to make sure that patients aren't getting multiple prescriptions from multiple different clinicians and multiple different pharmacies. Sort of interestingly, even though we are taught to always do this, in my work as an addiction doctor, I've actually never seen a single instance of a patient shopping around for multiple prescribers. But we're still supposed to check. We talk to parents and talk to them about how to keep medications locked up, to safely administer them directly to their child or adolescent so that they watch the medication go in and that they can keep an eye on how many pills are in the bottle to make sure that nothing goes missing. And then we talk to caregivers about how to get rid of medications when they're done. In our communities, there are often medication drop boxes that people can drop off leftover opioid prescriptions. Actually, it turns out it's probably not the best for the environment, but actually it is okay if you're in a pinch to flush medications down the toilet. In the US, the Food and Drug Administration says that's what you should do to get rid of your medications if you have nothing else to do. And the Environmental Protection Agency says that's probably not good for the environment. So we have this really interesting conflict in the US. But I think if a child's safety is under question and you're just flushing a few medications down the toilet, like you might consider that as an option if you have no other better way to get rid of them. And then we want to talk about naloxone and talk to youth and families about how to identify the signs of an overdose and what to do to intervene. And we'll come back to this topic. So this final bullet point is a new recommendation that up until now in the US and also in Canada, if you got prescribed an opioid, you didn't necessarily get it with naloxone. Now the recommendations in both of our countries are if you're prescribing opioids to a young person, alongside that opioid prescription, you should also provide them naloxone which is the antidote to an overdose in case there's an issue with that opioid. So that was just a little detour into opioid prescribing because, again, it's something that comes up in clinical practice, and I think we're trying to be more thoughtful about how we treat and manage pain with young people. Now I want to come back and talk about evidence-based treatment and harm reduction, and here's where I've really learned a lot from folks here in Victoria and in British Columbia. The truth is, when it comes to opioid use disorder, or OUD, which is the term that we use to describe opioid addiction, we don't do a great job of getting young people who would benefit from evidence-based treatment into care. And part of it is probably because doctors like me who are able to treat folks are sitting in clinics that aren't meeting young people where they are. Be that as it may, if you look in the US context, the prevalence of opioid use disorder across the entire US in young people aged 12 to 25 is 1.2%. That means about 1 in 80 young people living out in the world has an opioid addiction. But if you ask the question, how many actually get diagnosed, that's the next bar over. And the blue portion of the bar represents people who are actually diagnosed and identified, and the red portion of the bar represents the percentage of people that never get identified. So most people don't even get identified by a clinician. The next bar over is how many people actually start treatment. It's even fewer. The next bar over is how many people start on medication, which we'll talk about is really sort of an evidence-based treatment that can help with survival and has a mortality benefit. Even fewer. How many people stay in treatment for a month? Even fewer. How many people stay in treatment for 6 months? Even fewer. So you can see that as a healthcare system, we're not doing a good job of identifying, getting people into treatment, and then retaining them in treatment. Layered on this in the US context, and I would love to hear your perspectives on what you've observed here and what you know about the data here. In the US context, we have historic, longstanding systemic racism that has contributed to massive inequities in our delivery of addiction treatment for young people, such that even though these numbers look bad for everybody, these gaps are even bigger when we talk about youth of color in the US. That Black and Hispanic youth are less likely at each of these stages to receive each of these milestones of care. There are, in the US context, 3 approved medications to treat opioid use disorder or opioid addiction. I actually haven't listed them all here because I actually think the Canadian guidelines are better. And so I'm actually focused here on what the Canadian guidelines recommend. And the Canadian guidelines say that for treatment of opioid use disorder, we have 2 first-line medications and a second-line medication. And the first-line medications are buprenorphine and methadone. And I'll talk about these in a second. These are opioid agonists. An agonist is a medication that binds to opioid receptors and has an effect. And what that does is when we sort of have the medication bind to opioid receptors, it decreases withdrawal symptoms for people, it decreases cravings, and it makes it less likely that people will feel like they need to use to make those uncomfortable feelings go away. Slow-release oral morphine is considered a second-line medication, but can also be very effective at, again, binding to the opioid receptor and reducing cravings and withdrawal. And these medications don't just treat cravings and withdrawal, but they're associated with reduced use of opioids that people buy from the illicit market. They're associated with reduced mortality, meaning that people who are on medications survive longer. They're associated with retention and addiction care, meaning that people who get medications are more likely to come back for treatment. They're recommended by the American Academy of Pediatrics. The Canadian Pediatric Society, too, also endorses these medications for young people. And they're typically offered alongside behavioral health services like counseling, although in our context, we make sure that people get medications even if they aren't ready or interested in engaging in counseling at that time, because these medications have been shown to save lives, and they save lives regardless of whether somebody gets counseling alongside them. So even though I know that most of my patients will benefit when they get counseling, we certainly don't view it as a requirement because we want them to get these life-saving medications. When I talk to my pediatrician colleagues, I highlight that there's a lot of great training out there. I recognize that prescribing new medications when you've never done it before is really hard. I'm somebody who isn't necessarily on top of my medications to treat high cholesterol. And so I can always benefit from training to help me prescribe a new thing. And so there's actually great training for pediatricians through this website that I've listed here. One thing that comes up all the time in my clinical practice, and I have a lot of parents ask me this when their teen is thinking about going on a medication, is, wait a second, you told me that my child has an opioid addiction, and you want to put them on an opioid to treat them, right? Buprenorphine, methadone, and morphine are all opioid medications. So you're treating addiction with an opioid. Why does that work? Well, here's why it works. When you're using heroin or fentanyl or short-acting pills as part of an opioid use disorder, you use, and when early on in your use, you might experience a high, that sort of psychoactive high, sort of for many people is sort of a positive experience when you use an opioid. But they're short-acting, which means that your body metabolizes them, and then you have to use again in order to achieve that high again. You sort of have to use again and again, often multiple times a day, in order to achieve that high. But as time goes on, you develop tolerance, and that high becomes difficult to attain, if you're even able to attain it at all. And in the meantime, when you're not using, you start to develop these really uncomfortable withdrawal and cravings. And this is especially true in young people whose brains are still developing, a little bit more plastic. This bouncing between experiencing withdrawal and cravings and then the potential high is just really extreme. And so you end up spending a lot of your time bouncing between these things and then using opioids like fentanyl in order to sort of regulate. And so the idea behind buprenorphine, methadone, and slow-release oral morphine is that these are medications that are longer acting, and they can also be carefully dosed to get somebody into the right therapeutic range. So if you take somebody who is sort of experiencing withdrawal and cravings from the last time they used, say, fentanyl, and you time it and you dose it just right, you can actually get someone on a medication that's given every 12 to 24 hours that actually gets them right in this in-between zone where they're neither experiencing the high of opioid use nor the uncomfortable withdrawal and cravings that might drive them to use. And so somebody can actually feel normal, which, for the young people I work with means that they can go to school, they can engage with their friends and family again, they can engage in employment if they want to, they can engage in the behavioral health services that they might be interested in receiving. And so that's why these medications work. In the US, we also have an additional medication that's available that isn't approved in Canada. It's naltrexone, which is available as a long-acting injectable that goes by the brand name Vivitrol. And its basic premise is that naltrexone is actually an opioid blocker, meaning that for somebody who's using opioids, if you give them this medication, which is given every month or so, that you block all the opioid receptors in their brain so that if somebody uses fentanyl or another drug, it's not able to act because it's not able to get through to the receptor. And so naltrexone kind of blocks that high or that reinforcing effect of using opioids. What's really interesting about this medication is that it also blocks cravings for other things. To get down into the weeds a little bit, in our brains, the neurologic pathways that mediate cravings are mediated by endorphins, which are the natural opioids that occur in our own neurotransmission. And so when you block the natural endorphins in your brain from being able to act with this medication, you often block cravings for other things. And so in our adolescent medicine practice, we sometimes use naltrexone not just for opioid use disorder, but we use it as a medication that's effective for alcohol use disorder because it blocks cravings for alcohol. It also blocks cravings for binge eating for patients of ours who struggle with binge eating. For patients who engage in self-cutting behavior or other sort of self-harm behaviors, it can blunt the cravings to do those things. And so it's a really fascinating medication. In theory, it sounds like it would be a very effective medication for a lot of different reasons. In practice, I don't think it's really borne out to be that, but we do sometimes use it. A lot of families ask me, how long does my child need to go on one of these medications for? And we haven't really known the answer to that. We've got a study that's going to be published in about 2 weeks that actually looked at this question. So we used data from more than 11,000 adolescents and young adults in Massachusetts who we sort of tracked through our centralized health system to understand what happens to people when they go on medication. And what we found is that if you look at patterns of use of these different medications that we've been talking about, when people go on medications, it turns out that about a quarter of them stick to this green line that you see here. This is the x-axis in this figure is 1 full year plotted out by the number of weeks, so 0 weeks on the left to 52 weeks on the right. And then the y-axis, the up-down axis here, is how adherent were they with that medication, meaning like how often did they take it, what percentage of the time. And it turns out that about a quarter of young people follow this green line, meaning that they take it for about a year and they're adherent, mostly adherent on the medication for about a year. About a quarter of young people are this blue line, which is they go on the medication, but then they kind of stop, but then they go back on, and then they go stop, and they go back on. So they take it for a year or so, but they kind of come on and off it. The orange line represents people who go on the medication and take it for a little bit, but after about like 3 to 9 months, they come off it. And then the red line is the people who go on the medication, but then kind of stop it pretty quickly. So then we ask the question, all right, so now that we know that these are the different ways in which people use medications when they're a young person, what happens to folks? And so we looked a year after this to find out what happened. And it turned out that that green line, which is sort of high adherence to medication for at least 12 months, everybody else that you see had a higher risk of overdose and a higher risk of hospitalization. And so what that tells me is now when I'm talking to families, I tell them, like, look, nobody likes to go on a medication and stay on a medication for a long time, but the studies show us that when young people go on medication and stay on it for at least a year, the outcomes tend to be better. And so that's how I've started to move towards counseling patients that I work with. I certainly do not require that, but it is nice to have some data to help families make an informed decision. And of course, treatment is just one piece of this, right? We also want to talk about overdose prevention, because even as I'm helping a young person to stop their opioid use or to cut back on their opioid use by providing them treatment, we know that there's still a dangerous drug supply out there, and that if people use, they're still at risk of overdose. And so I make sure that I talk to all of my patients about counterfeit pills or pressed pills. I make sure that I talk to them about the fact that sometimes the cocaine supply or MDMA supply can have fentanyl in it. I talk to the patients that I use, that I care for, about making sure that they're using with other people, so that there's someone available to call 911, and that they should stagger their use so that somebody is able to call 911 if somebody overdoses. Framed in the negative, I like to frame it in the positive: use with others, but you might also say, don't use alone. I just try not to. I really try not to wag my finger with young people, so I try to avoid using the word don't. But that's really the idea, is to make sure that you've got somebody there. You want to start with a little bit to assess its effect. And so, if you're thinking about using a pill, I counsel the patient in front of me to snap it in half and then snap it in half again, and just start with a quarter and see how potent it feels. And then maybe 20 to 30 minutes later, you can consider using more. Avoid polysubstance use, meaning avoid mixing pills with other substances. We talked about how that's a risk for overdose at the beginning. Even alcohol is a sedative and can put you at risk for overdose. I talk to young people about calling 911 in the event of an overdose, that Good Samaritan laws protect people who call 911 and do the right thing to make sure that people get medical attention when they need it. A lot of the young people that I work with are afraid to call 911 because they know that the police might show up, and they're aware that they've been using drugs, and they worry about what that means. But we really want to encourage people to make sure that medical attention is coming. And then, of course, central to all of this is really carrying naloxone. And as I said, in the U.S., we largely are using nasal spray. I know that in many places in Canada, including British Columbia, more readily available at pharmacies is the intramuscular version of naloxone. Although I come to understand that actually the intranasal version is going to be rolled out more widely in the province. Bottom line is they're both highly effective, and they can save a life within minutes. And so I make sure that my patients all have access to this medication, and we talk about where to get it. And then there's other harm reduction services that we're providing in our clinic. So we make sure that even as a young person is continuing to use drugs, that they understand that they can get services from us to help keep them safe. And that includes things like testing and prevention of HIV, testing, prevention, and treatment of hepatitis C. Making sure that they're getting access to good sexual health services and reproductive health services. All of these things helping to keep young people safe and healthy, so that if they are ready to get treatment, they know who to turn to, and in the meantime are staying safe. We also give out fentanyl test strips to our patients in our clinic to take home. Our government gives us these as doctors to hand out in our clinics. And they, I think people in the era of COVID have gotten used to the idea of how do you use one of these. What you do is you take just a little bit of the drug you're about to use, you dissolve it in water, and then you dip one of these test strips in, and then you lie the test strip flat. This says 2 minutes, but often they need about 10 to 15 minutes to fully act. And if there is not fentanyl in the substance that you're about to use, you'll have 2 lines, and if there is fentanyl and it's a positive test, you'll drop down to 1 line. I have to talk to young people about that because I think people are used to COVID tests that go in the other way, right? A COVID test is negative when it's got 1 line, and it's a positive COVID test if it's got 2 lines. These test strips work in the opposite direction. As I was saying to the group that I met with this morning, I use these as the centerpiece of a conversation that is centered on safety with a young person. The truth is, in Massachusetts, where I practice, in most parts of the US and probably most parts of British Columbia, fentanyl is everywhere. And so if this test comes back negative, you actually probably should still presume that there might be fentanyl in what you're about to use, and should still exercise all of those safety measures that we talked about. Okay, so with that as the backdrop, I just want to talk here in my final minutes about some of the barriers that we have. And this is true kind of all across North America, although I'm going to share some of the US perspective here. The first thing is that we just don't have a lot of youth-focused addiction providers. Most of our workforce in addiction medicine, which is already pretty short-staffed, is focused on adults, and there are very few people that are focused on teens and young adults. And in fact, in the US, among all doctors who prescribe buprenorphine, only about 1 in 50 actually has pediatric training. And I know this is also true in the treatment context here, that often what happens is once you turn 18 or 19, you start going to the adult treatment service world. And so you might be an 18-year-old receiving your addiction treatment alongside 40 and 50-year-olds. And that doesn't feel developmentally appropriate. We have the same problem in Massachusetts and in the US, and it keeps a lot of young people from seeking treatment because they want to go to a place where they feel like they're being seen alongside their peers. We have a limited availability of addiction treatment programs in the US to prescribe. We actually did a national survey of all of the addiction treatment programs in the US, and we called them. We did sort of a secret shopper study where we pretended to be a family member looking for treatment for a child and asked, do you have access to evidence-based medications? Well, it turned out that only 24% of them offered buprenorphine, which is the gold standard addiction treatment medication in our context. And in fact, a lot of programs had anti-medication policies that actually, of the remaining programs that didn't offer buprenorphine, half of them said, before you can even come to our program, you have to come off your buprenorphine that you're on, which is completely contradictory because we know that buprenorphine is actually associated with, it has life-saving properties. It's associated with improved survival in people who use drugs. And yet, treatment programs were forcing young people to come off their medications in order to get treatment. There are, in the US, big restrictions in place on access to methadone for people under age 18. It's just very difficult to locate methadone-based treatment for adolescents in the US, despite the fact that methadone across studies seems to be one of the most effective medications to treat opioid addiction. And then, as I alluded to before, there are historical inequities that we have to think about that layered on top of all of this, we know that access and services delivered to youth of color and other backgrounds that have been historically disadvantaged just really sort of create even bigger divides. And in the US, we have huge issues making sure that we're delivering effective treatment to young people based on race, but also language, insurance status, because we don't have universal health care, socioeconomic status, and then geography. There's a lot of sort of different things for us to think about when we're delivering treatment services to teens, because we are getting better at delivering addiction treatment to adults, but there are some unique ingredients that go into teen addiction treatment. The first thing we have to think about is that teens and young adults are often undergoing a lot of transitions, that they are having increased autonomy in their own healthcare decisions, healthcare decisions that don't involve parents. They may be living out on their own for the first time. They may be having educational transitions if they're going from high school to university or another place, having transitions where they may be taking on their first job for the first time. In the US context, there's often big health insurance changes once you become an adult. You might switch private health insurance plans. And we also experience in our treatment programs a lot of ambivalence surrounding treatment. A lot of young people are brought into treatment by their parents who say, you have to go to treatment, come with me. And so then you have an interesting situation where you have a young person who isn't ready in that moment to proceed with treatment, but their parents are trying to make them do it. And young people also, aren't used to the idea that you make an appointment to go in for treatment and you might not be able to have that appointment for another week or two. But I think a lot of times, our treatment seeking or our interest in treatment can change from moment to moment. And so you might be interested today, but tomorrow that could change. And so that makes we have to sort of be ready and flexible to meet people when they're ready. On the other hand, there's a lot of hope because young people are often very early in the trajectory of their addiction. Whereas my adult treating colleagues often are working with people who may have been using for decades. The young people I work with might have only been using for a year or two. And so that gives me a huge opportunity to affect change that I think my colleagues who work with adults don't necessarily have. And many young people have never received any evidence-based treatment like use of medications before. So I get to be a person who is offering them something that we know works and can be very helpful. But on top of this, a lot of young people are still learning how to navigate health systems for themselves, may again be presented without parents. And so we use a lot of flexibility in our clinical services, recognizing that young people may often show up late or they may miss their appointments, and being prepared to work with them, because we know that keeping and maintaining appointments is actually a really tricky skill that I'm not even that good at. I'm going to move through the next few slides relatively quickly, just because I want to make sure that we have time for discussion. I just want to share that part of the work that we're doing with pediatricians in the US and also here in Canada is to help clinicians learn how to ask about overdose in their practice. And a colleague and I partnered with a mom who lost her 19-year-old daughter to an overdose to write this piece that we published last year. And it provided some scripts, some things that pediatricians can say and talk about with teens and families to help understand what a young person's risk is and make sure that they're having these conversations. The idea here is that we as pediatricians do something called anticipatory guidance, which means that when you bring your baby into an appointment with me, I will always talk to families about putting your baby back to sleep. When your child comes in to see me and they're 5 or 6 and they're riding a bike, I will always talk to you about, hey, make sure you're wearing a helmet. When you're a teenager, I'm always talking to you about, hey, wear a seatbelt when you're in a car. Now that we know that overdoses is the 3rd leading cause of death in the United States and a leading cause here in Canada too, we should be routinely having conversations about overdose with young people. And so we're trying to get the pediatric workforce to take this on more routinely. And I just want to share with you a final thing that we're doing, because this has a British Columbia twist to it. So we have a new NIH-funded grant, so U.S. National Institutes of Health funded grant that Harvard, where I work, is doing in partnership with University of British Columbia, where we are working with young people and families and clinicians in both of our 2 separate communities to figure out how do we build a toolkit and suite of services that the clinicians who are working in our area can routinely incorporate into their practice when they're working with adolescents and young adults, to make sure that we're all kind of routinely addressing overdose. And I'll just move through this quickly to say that we're trying to tailor this to our local needs. We are just in the 1st year of the grant right now, and our first aim of the grant has really been to actually just do interviews with young people, with their family members, and with clinicians to figure out what is needed to go into services. How do people want to have these conversations, and what does it look like? And our next steps as we wrap up these interviews will be to actually develop a toolkit, to train clinicians on it, and then to see what happens, to actually do a pilot study. This pilot study will be conducted throughout actually British Columbia, based out of the Foundry programs that see young people in BC, and then also will be based out of pediatric primary care offices in Massachusetts, to see, do clinicians like this? Do families like this? Do they like routinely having these conversations about overdose? And does it help to keep people safe? We've got a few key preliminary findings that have come out of these interviews. We've done about a little over half of these interviews with youth, family, and clinicians to find out what they want. And some things that we are learning include that really this needs to be built on relationships, that we need to first build trust between young people and their clinicians, so that these conversations are meaningful, and being really connected to the whole individual in front of us, and not thinking just about their drug use, but about the full person that they bring to the clinical encounter. One thing that particularly comes up in the US context is that pediatricians are really worried about time constraints and the fact that they have to see a lot of patients and do a lot of work, and this is yet another thing we're asking of them. So we're trying to figure out how do we make this crisp and easy and fast to incorporate into their practice, and also how do we build support, maybe even financial incentives for pediatricians to more routinely do this. And we're also learning, we've learned a lot actually from partnering with Foundry, learning that, you know, providing food, drinks, transportation, and other things are really kind of a key component of helping young people feel welcome in clinical spaces, because, again, we are a little bit ivory tower, and we have a lot of barriers to break down to help young people feel they can trust us and engage with us. And so we're learning how to more routinely incorporate some of these other ingredients as well. So I will stop there, and I'd love to use the rest just to discuss, and hopefully I can learn from you. Thank you.
Okay, I just wondered, in that nice graph you had where you had the people that stayed with it for 12 months, can you offer parents and kids any sort of like words of that it actually gets better over time, or this doesn't mean you're going to be feeling the same at the beginning as you might be, like, can you make it, like, you want people to try and stay on it for 12 months, but what incentives can you offer them?
Yeah.
Did you do any qualitative work at the same time you were doing work?
Yeah. It's a great question. I'll kind of repeat it back into the mic just in case for the recording purposes. So the question is, you know, as we're actually having conversations with young people and families about going on medication and staying on medication for 12 months, I think the question is, like, what's in it for them, right? Because this is a tension that comes up, and I didn't unpack this when I presented this, but you know, the young people I work with don't want to go on a medication for a long period of time, right? When I talk to my adult addiction treatment colleagues, they'll tell me that some of their patients say, you know, I used heroin for 20 years, and now I've gone on a medication like buprenorphine, and I can't imagine ever coming off the medication. I'll probably be on it for life. And they hear that a lot, and it's because the medication is so helpful and supportive that they just can't, it'd just be too hard for them to actually come off, and they worry about the risk that they would experience. The young people I work with, and that I'm sure you know, don't think like that, right? Like, when you are 18 or 19 or 16 or 24, you don't imagine that you're going to go on a medication for a chronic condition and stay on it for life, right? People don't like that when it comes to hypertension or diabetes. They certainly aren't going to like it when it comes to opioid use disorder. And so that's the constant tension that we're walking, is that many young people and families feel very internally motivated to come off medication as soon as things are getting better. And so I don't know that I figured out the magical way to talk about this, except to say, to acknowledge what I just said, the idea that, like, nobody wants to go on a medication for a long period of time. But I think it's worthwhile us recognizing that when we look at how people do when they go on medication, people tend to do better when they stay on it and take it consistently for at least a year. And so in that way, we might think of it almost like an antidepressant medication to treat depression, is that you typically don't go on medication for depression just for a month or two. We typically have you go on medication for, you know, a year or two, And we wait until things are better. We wait until a good, appropriate time that feels right in your life to think about weaning off that medication. And then let's try it then. Let's do it together in partnership. And if at any point you decide that you want to stop the medication, I respect that. Please come and talk to me first, and I'll help you figure out the safest way to do that, even if it's faster than a year, because I want to do that in partnership with you. And so in practice, what we'll do is, patients will be on a medication for a year or 2 or 3, and when they decide that they want to wean off, we won't do it in Massachusetts, in Boston, when it's snowy and it's January and it's minus 20 Celsius. We do it in the summer when they're on break, in college, and it's sunny out, and they're, it's just like a better time to do it. And we find the right time and individualize that. Great question. Yes.
What are the symptoms or not the symptoms? Sorry, the criteria? No, not the criteria. Sorry, I forget. It just
Side
lost
effect?
my train of thought.
Side
But when you're taking the medication and there's
The side effects.
side effects, yeah.
Yeah. So it's really interesting. So the question was, what are the side effects of medication? So all of these opioid agonist medications can have the same side effects as opioids. In the case of methadone and morphine, you could overdose on them if you took too much. You actually can't overdose on buprenorphine very easily for reasons we won't get into. But they have the same set of side effects that opioids do, meaning that probably the most common one I see is constipation. So a lot of my patients are struggling with constipation. If you go to too high of a dose, sometimes people can feel somnolent or sleepy throughout the day. And I actually find my patients, because they're younger, are often somnolent on much lower doses than my colleagues who work with adults see their patients get somnolent on. There's various different side effects kind of related to just sort of like GI upset that I see. So I'll see like some soft nausea. Some of my patients will, especially when they're first starting medication, actually feel like they actually are going to throw up, or sometimes do throw up in the same way that some people who get an opioid in the setting of like a broken arm or whatever will throw up when they get morphine. So we'll sometimes see that, but most of that can be avoided by just sort of very carefully titrating to the right dose for a patient. But the constipation is the one that comes up all the time. And it can be really uncomfortable. Yes.
I'm more familiar with reading about youth and alcohol abuse, and from what I understand, a user of alcohol in their youth stopped their brain development, and I wonder if these agonists do the same in treatment.
Yeah, this is a really, really good question, and a central question in the field that we haven't answered yet. So the question was, so the person who spoke sort of brought up the idea of alcohol use disorder, and the fact that we know that when young people use alcohol, it potentially can impact development. In fact, the thing that we worry a lot about is that people who use alcohol at a young age are much more likely to go on to have lifelong problems with alcohol addiction the younger they use. And so if you use alcohol for the first time when you're 13 or 14, you're more likely to go on to have a problem with alcohol use disorder in your lifetime than if you first start using when you're 17 or 18 or even 20 or 21. And so then there's this question of, when it comes to opioid use disorder, if we're giving opioid medications to treat opioid addiction, what are the developmental implications of that? Are we putting somebody at risk for addiction? And we don't know. I acknowledge that those studies, I think, are underway based on my understanding of what the funding has looked like, but we don't know. I will say this, that if you have a young person, the way I view it is, if I have a young person who's in front of me and they've been using fentanyl and they're at risk of overdose and death, and they're using fentanyl, and so they're already exposing their brain to highly potent opioids, that these medications, which are associated with improved survival, are going to help keep a young person safe, are probably the safer thing for them to be having their brain exposed to. Yeah, exactly. But it does, I think, speak to this earlier point of like, what is the right amount of time for somebody to be on medication? I think our studies show that it's probably more than a year, but You know, is 2 years too much, 3 years too much, 4 years too much? Is that exposing somebody to a lot of opioids that maybe they should have been weaned off earlier, and we don't know?
So you're saying, so it's an unknown yet.
It's unknown.
Okay.
I'm just wondering if you have concerns. I don't know if it's a trend that here is developing out here, but essentially that a lot of clinicians are prescribing or making use of preventive patches just because it's chemically feel like that's why it's more often than especially with younger population that are hard to reach. We have to be concerned with that. More often, with more stable clients, they'll be happy Overdose or Suboxone, but I'm seeing a lot more younger people talk about that. Is that
Yeah, so this is a great question. So the question, I think, gets at the idea of safer supply, something we've been talking about a lot this morning, the idea that if you have people who are out in the community using fentanyl or fentanyl-contaminated products where the dose is not clear, that puts them at enormous risk for overdose. And so there's increasing use of safer supply, which is sort of medical-grade fentanyl and fentanyl patches, which are a known potency, a known dose that helps address somebody's withdrawal and cravings and gives them a safer supply for it. I think we don't know for youth. I think again, I think the harm reduction approach would say that we meet people where they are and we give them the services that keep them safe, so that ultimately, if they are interested in treatment, they know who to turn to and who to trust. I think with youth, it's a little bit more complicated when it comes to thinking about harm reduction and safer supply for a couple different reasons. The first one is, as we've just discussed, like the brain is still developing, and so there is this balance to strike of keeping somebody safe, and in the case of treatment, giving somebody potent, consistent, sort of constitutive opioids for long periods of time, and what effect does that have on the brain versus kind of keeping them safe. I think the other thing that's a little bit different for youth, and here I'm going to say something that might actually feel sort of controversial, I think, to some folks, particularly when viewed through the harm reduction lens, and that is that, and when it comes to young people, especially when we're talking about adolescents, yes, the principles of harm reduction are central, and we need to keep people safe, and we need to meet them where they are. I also think that in harm reduction service delivery to young people, because they are young, and because they are more vulnerable, and because we have this opportunity to prevent lifelong addiction, I actually think it is incumbent on us, as we're providing harm reduction services, to figure out the right way to actually work to help get a young person into treatment. That I think it's different if you're talking about an individual who may have been using later on in life and is using drugs and not causing harm to anybody, and wants to continue to use drugs and wants to receive harm reduction services to keep them safe. I think that's really critical, and we meet that person where they are. I think when it's a young person, I do think we have to go that extra step of actually figuring out the right set of motivational enhancement and incentives to help sort of connect a young person to treatment. So those are the things I think about when I think about sort of safer supply as applied to young people.
Moving slightly upstream, if you were advising school districts about school-based drug education, knowing that the DARE program, just so you know, is discredited, what would you offer instead? What do you teach young kids about drug use?
Yeah, I think this is such a great question because, so the question was about like drug prevention and what works. And I think you're right, like drug prevention has gotten such a bad rap because there's been some really bad drug prevention. And I think many of us in this room received some of it, right? I so distinctly remember it. In fact, actually, we vacation in Maine every summer, and the drive that we take up to it's the place that we stay in Maine. Actually, somebody owns one of the original DARE vehicles, like the original drug prevention DARE program. It's It's like an old 80s Corvette that's black and has like Dare blazoned all over it. And I really want to talk to that guy and figure out where he got it. I've seen him outside of it sometimes. But it's just a reminder, like there's bad drug prevention that I think is kind of sort of sullied the reputation of drug prevention. But drug prevention has come a long way, and there actually are some really effective school-based prevention programs. And increasingly, we're seeing them rolled out in Massachusetts. They've really like had an eye towards what are the evidence-based treatment program or evidence-based prevention programs that have a preventive, protective effect, and starting to roll them out. And some of the, I think, in my mind, some of the more promising ones actually were developed here in Canada at the University of Montreal. I think of Patricia Conrad's work in thinking about Preventure, which is basically a substance use prevention program that goes a little bit further than just saying everybody needs drug prevention, but actually really hones in on some of those risk factors that we talked about earlier, right? Young people who have mental health concerns like depression or anxiety or trauma or ADHD, because we know that feelings of hopelessness contribute to drug use. We know that feelings of anxiety and feeling sensitive to feelings of anxiety contribute to people using drugs. We know that impulsivity in the context of, say, ADHD can contribute to drug use. And so some of this targeted programming that actually helps young people who are at elevated risk by virtue of mental health concerns that they have, helping them get targeted drug prevention, I think is really promising. And that's actually something we've rolled out in Massachusetts as well. But I think, unfortunately, even as these programs were rolled out, the evaluation of them, I think, has often been lacking. And so in Massachusetts, we've rolled out all these programs, but we don't have outcomes data. So we imagine we're doing the right thing, but we still only know based on the original clinical trials that something seemed to have worked when we tested it in a clinical trial context. But we don't know in the real world, is it making a difference?
You've talked a lot about the United States and Canada having a fentanyl problem. And recently, I've traveled to other countries that don't have a fentanyl. UK, Japan, South Korea, Singapore. They don't seem to have this toxic drug problem that we have. Can you offer some insight as to why you think that is?
Yeah, it's a great question. So what is unique about North America that we've got fentanyl? A couple points. I mean, other places have different drugs. So there are parts of Asia that have more serious, for example, methamphetamine problems. Parts of Europe are seeing lots of nitazines. And so there are different drugs that affect different places. I think if you asked economists, they would probably say there's sort of an economic principle that underlies this, and it's the balance between supply and demand. That in the U.S. context, in the Canadian context, there are drug markets that are supplying drugs, and even as governments, especially the U.S. government, try to stamp it out with law enforcement, there is, on the other end of the supply and demand balance, there are people who are struggling with addiction and people who are generating a demand market for substances. And so because of that, we have a lot of drugs coming into our countries, or drugs being produced domestically in some cases to sort of meet that demand. So I think the way that we reduce that demand is through really going upstream and preventing substance use in the first place the best we can, but then also reducing demand by giving folks access to services that help them not use drugs if they're ready and want to not use drugs. Yes?
Thank you so much for your presentations. I was curious about thinking about mortality data, and among young people who die from an overdose death, is there any understanding of what proportion of those would meet the criteria for an opioid use disorder?
Yeah, that's a great question. So earlier on when I presented, I'll just keep scrolling back while I talk. When I presented these data, this same national look in the U.S. asked the question, how many young people had ever overdosed non-fatally on an opioid before they had their fatal overdose? And I'll also ask the question, how many had a known opioid use disorder before they overdosed? And the truth is, it's actually a very small percentage. It's actually not most. That what's really kind of, I think, particularly scary about this is that a lot of young people who are overdosing don't necessarily have a lot of indicators that they're at risk. They don't necessarily have a prior history of opioid addiction. They don't necessarily have a prior history of an overdose. Many of them do have other mental health conditions, though, meaning that they have depression or anxiety or history of trauma or ADHD. And in many cases, at least this is my sense, if this wasn't reflected in these data, which didn't ask this question, but I think often those symptoms are going unaddressed. And I think that speaks to our broader issue that many young people who have mental health problems never get access to effective treatment or services that they could benefit from.
What are your thoughts about the intersections of the field of psychedelic medicine emerging and pediatrics?
What are your thoughts? The question was the intersection of psychedelics and mental health and addiction treatment, and then also layered on that pediatrics. I'm curious, what do you think, just sort of like, or anybody in the room, what do folks think about psychedelics as applied to addiction treatment or mental health? Do we have any experts in the room?
Yes, he is.
Yeah. So let's hear. Yeah.
Well, I mean, I think it's a tremendously promising area of research. Phase 3 trials are nearing completion for a few options, new medication options. But one of the questions, they'll be approved for adults. The question is, what about the kids? So I wanted to know if you're paying attention to how Harvard's got a school of psychedelics. I mean, Timothy Leary was at Harvard originally, part of the downfall, but now that it's resurging, are you sort of watching the field, and what do you think?
Yeah. So I completely agree. I think it's very promising. I think, this set of slides that I put up, even though the epidemiology and the public health perspective has changed, when you talk about the treatment parts of these slides, these are the same slides I could have put up a decade ago. Like, the field is not moving nearly at the pace that it should. If you think about like cancer research and cancer treatment, there are constantly new medications and therapies coming out. There's been nothing in addiction. And so actually, for me, I agree, very promising that we may be on the verge of something new that is going to kind of unlock the field a little bit. So I'm very optimistic. I don't know what to think about young people. I think when it comes to young people, it may depend on the substance. When it comes to nicotine use disorder, for example, our treatments for nicotine use disorder and vaping in young people are pretty effective, and they seem to be more effective in young people than they are in populations of adults who have been smoking for years and years and years. And so I think if you're thinking about each of the different substances, it may be that some of our treatments, if we could roll them out more effectively for pediatric populations, they might be a little bit more effective than they are for adult populations. So the sort of the efforts might really just be that we just need to do a better job of getting them the evidence-based treatment that we know works, but we're not delivering right now. I think there's a whole other set of questions developmentally about what does it mean to, provide a psychedelic to a person who's, underage and in the eyes of the law, a child. I think probably those decisions will be made for us by policymakers, and we'll probably not anytime soon be in the position of actually being able to offer psychedelics to young people. So I may be able to dodge the answer to your question by saying I just don't know that it's going to be possible anytime soon. But like so many other things in pediatrics, I think we'll start by seeing what's the adult experience and then figure out are there ways we bring this down again. But I'm open to the idea. Yeah.
Thanks for your talk. One of the slides you had was about only about 2% of addiction providers having pediatric training. As I'm sure you know, the range of medical specialties that go into addiction medicine in the U.S. is actually much broader than in Canada. In Canada, it's much more family medicine based, and in the U.S. there's more. And so in Canada, it's even much less than that. And in some of the work that I do, I am trying to recruit pediatrics-based physicians to do more addiction work. As far as I know, in the vast majority of pediatrics residencies, there's almost no addiction training. And I know here in Victoria, on our pediatrics unit in the main hospital, we're having constant challenges with pediatricians helping to manage patients with substance use disorder, in addition with our addiction medicine colleagues. And not to put anything more on them, but they're so stretched as it is. So I guess my question is relating to pediatrics training for pediatric residents. Do you know of any work that's being done to sort of systematically increase the amount of exposure that young pediatricians are getting to substance use education, addiction education?
Yeah, it's a really critical question. So the question was around addiction sort of proficiency in pediatric training. So helping folks who are in training for pediatrics or family medicine sort of understand what are some of these basic principles that we should all incorporate into our practice. We did a study a few years ago that was actually a national survey. Actually, it was an international survey because it was both Canadian and US residency programs in pediatrics to find out what percentage provided any sort of education on a whole range of different addiction-related topics, meaning like medications for addiction treatment, naloxone and overdose prevention, drug use prevention, screening for substance use, all these different sort of proficiencies that a person could have. And the findings were pretty dismal, meaning that like there was, I think just as you had alluded to, next to nothing that was being done in most pediatric residency programs. I do think there's a lot of movement. One thing that gives me a lot of hope is that I see as a pediatrician just a real culture change within the field that especially younger physicians who are coming through and getting training are much more passionate about this. They've grown up in a time where they realize this is a public health emergency and a crisis, and we all have a role to play. And so I see a lot of trainees with a lot more excitement around taking this on. A lot of people who want to go into this field. For the last 4 years when I've been at Mass General, I was the only person in our program that provided any addiction treatment. We just hired 2 new faculty who were fresh out of training who both wanted to do addiction treatment. And there were other people that applied for the job who wanted to do addiction treatment. And so I'm just seeing that the field is changing. And I think that's probably the most important part is that even though we're not doing a great job training folks, the fact that people are interested, excited, want to do the work is probably the single most important thing. That culture change is critical. But you're right, like we now need to back that up by giving more experience. We need to make sure that people are routinely getting addiction treatment experience just in the same way that every pediatric resident has to do a cardiology rotation. I think we really need to build these skills into pediatric training. That's where I think a lot of programs are falling short.
We have time for one more question. This guy needs to get to Carrie.
And a burger.
$50 burger.
Yeah.
I am a retired nurse and health policy analyst and advocate with Lone Stop Farm, which is a national organization providing support and advocacy for families who've lost people to overdoses. And I'm familiar with a lot of what you presented, but from our perspective, we are in a crisis of loss of hope. So when you deal with families and you look at the ways to get into appropriate treatment, when you look at the difficulty with, being able to access overdose prevention or drugs, or the difficulty of the young person who may need methadone, but they're having to show up constantly and not being able to take care of everything that goes in. What can you say to me that I can take back to my organization to say that physicians and people that treat this health problem, do you see improvement? Because we still see a really high number of people dying and see a little bit of a drop. So what can you say to provide some sort of light?
Yeah, I think it's a great question. The question is around hope, especially for families who are looking to help save their young family members now, right? So the thing that probably brings me the most hope is actually what we were just discussing, that I'm seeing a change of foot in the field. That's a slow change. It's one that has been unfolding under several years, will continue to unfold in the years to come. I think that may not bring a lot of comfort to families who are looking for support now. So I completely acknowledge what you were saying. I think the hope comes from actually a lot of the community services really passionate folks, many of whom are not clinicians, but actually folks working in their communities, community health workers, social workers, sort of, you know, not the doctors that are on the front lines of delivery and are working every day, especially in British Columbia, to keep people safe, who view people first and foremost as human beings, and first and foremost are thinking about people's safety and dignity. That I think is what really brings me hope. I hope it brings you hope as well, because that's what I see that is available now, not in nearly enough supply and not with nearly enough funding, but are the people who are doing the work now and are helping now.
My biggest piece of hope, I think, is the fact that we did the study with the foundry. From my own personal experience and my son's struggle, the foundry was the organization that was able to offer him the best care, the most compassionate care, and care that had worked for him for a certain amount of time. So I'll be very interested to see what the results come from this.
Yeah, please, I put my email address there. I'd be happy to be in touch with anybody, including around the training needs, by the way, if you want to connect separately. Yes, I completely agree that the Foundry is a really impressive model. Thank you, everybody.